Which parameter must be routinely measured before initiating cardiopulmonary bypass to ensure the patient is safely anticoagulated? A. Prothrombin time, PT. B. Activated clotting time, ACT. C. Thrombin time, TT. D. Bleeding time. Answer: B. Activated clotting time, ACT. Explanation: the ACT is the gold standard bedside test used to monitor high-dose heparin therapy during cardiac surgery. To safely initiate CPB and prevent catastrophic clot formation inside the artificial surfaces of the circuit, the ACT must typically be prolonged beyond 400 to 480 seconds. What is the fundamental difference between a hard shell and a soft shell venous reservoir? A. Hard shell reservoirs cannot handle cardiotomy suction blood. B. Soft shell reservoirs collapse as they empty, minimizing the blood-air interface and reducing the risk of air embolization. C. Hard shell reservoirs require a vacuum-assisted mechanism to drain at all times. D. Soft shell reservoirs have an integrated open-screen filter for bone fragments. Answer: B. Soft shell reservoirs collapse as they empty, minimizing the blood-air interface and reducing the risk of air embolization. Explanation: soft shell reservoirs are closed bag systems that expand or collapse depending on the volume inside. Because they lack a large air-blood interface, they reduce blood activation and will naturally collapse if drainage stops, preventing air from being pulled downstream. Hard shell systems are open to the atmosphere, rigid, and require explicit level monitoring. During CPB, a perfusionist notes that the pre-oxygenator pressure is rising significantly, but the patient's systemic arterial pressure remains normal. Where is the most likely obstruction? A. Inside the oxygenator itself, e.g., fiber clotting. B. At the tip of the aortic cannula. C. In the venous drainage line. D. Within the left ventricular vent line. Answer: A. Inside the oxygenator itself, e.g., fiber clotting. Explanation: measuring pressure before the oxygenator helps monitor the resistance across the oxygenator bundle. If the pre-oxygenator pressure climbs while downstream systemic pressures are fine, the obstruction lies within the oxygenator itself, frequently caused by progressive clot formation or fiber fouling. What is the main purpose of the left ventricular (LV) vent in a standard CPB circuit? A. To deliver warm blood to the myocardium. B. To decompress the left ventricle and prevent distension caused by bronchial blood flow or aortic insufficiency. C. To act as the primary arterial return cannula. D. To monitor right atrial pressures. Answer: B. To decompress the left ventricle and prevent distension caused by bronchial blood flow or aortic insufficiency. Explanation: even on full bypass, the lungs receive a small amount of systemic blood via the bronchial arteries, and a leaky aortic valve can cause blood to back up into the LV. If the LV distends, myocardial wall tension increases, causing ischemic damage. The LV vent active suctions this blood out to decompress the muscle. Which safety feature prevents the retrograde flow of blood from the patient back into the CPB circuit if a centrifugal arterial pump stops spinning? A. An automatic electronic line clamp on the arterial line. B. The natural occlusive design of the centrifugal head. C. A one-way pop-off valve in the venous line. D. A continuous purge line on the cardioplegia system. Answer: A. An automatic electronic line clamp on the arterial line. Explanation: unlike roller pumps, which physically squeeze the tubing shut, centrifugal pumps are non-occlusive. If the motor stops or slows down while connected to the patient's higher systemic blood pressure will push blood backward through the pump into the circuit. An automatic, fast-acting electronic line clamp is mandatory to prevent this sudden exsanguination. Which type of gas flow adjustment is used to selectively lower the patient's arterial PCO2 on a membrane oxygenator? A. Increasing the fraction of inspired oxygen, FiO2. B. Increasing the sweep gas flow rate. C. Decreasing the water temperature in the heat exchanger. D. Adding volatile anesthetic gas to the blender. Answer: B. Increasing the sweep gas flow rate. Explanation: carbon dioxide removal on CPB is directly proportional to the sweep gas rate, the volume of fresh gas flowing through the hollow fibers per minute. Increasing the sweep gas flushes CO2 out of the oxygenator fibers faster, widening the concentration gradient and lowering the blood pCO2. Oxygenation, PO2, on the other hand, is managed by adjusting the FiO2. In the context of CPB equipment, what is the role of the cardiotomy suction? A. To vent air out of the pulmonary artery. B. To aspirate shed blood from the surgical field and return it to the reservoir for filtration and reinfusion. C. To deliver microplegia directly into the coronary ostia. D. To pull a vacuum on the patient's urinary catheter. Answer: B. To aspirate shed blood from the surgical field and return it to the reservoir for filtration and reinfusion. Explanation: Cardiotomy lines use roller pumps to actively suck blood out of the chest cavity, the surgical field, during an operation. This shed blood is heavily contaminated with tissue fragments and air, so it is routed through the cardiotomy filter reservoir to be cleaned before rejoining the main circulation. Why are arterial cannulas engineered with thin walls and specialized profiles, e.g., flared tips? A. To maximize the internal diameter, thereby minimizing velocity and shear stress on red blood cells. B. To ensure they can be easily crushed by a manual clamp in emergencies. C. To allow the perfusionist to inject microbubbles into the aorta. D. To completely block flow to the carotid arteries. Answer: A. To maximize the internal diameter, thereby minimizing velocity and shear stress on red blood cells. Explanation: high-velocity blood jetting out of a narrow cannula can cause significant hemolysis, turbulence, and damage to the aortic wall, potentially causing a dissection. Thin-walled designs provide the maximum possible inner diameter for a given outer scale, keeping flow velocities and jetting forces within safe limits. Which of the following describes the alpha-stat strategy for blood gas management during hypothermic CPB? A. Blood gas values are corrected to the patient's actual hypothermic body temperature. B. Blood gas values are measured and kept at standard physiological parameters, pH 7.4, pCO2 40 mm of mercury, at a constant 37 degrees Celsius, ignoring the patient's cold state. C. Carbon dioxide is actively added to the circuit to induce cerebral vasodilation. D. The oxygenator is completely turned off during cooling phases. Answer: B. Blood gas values are measured and kept at standard physiological parameters, pH 7.4, pCO2 40 mm of mercury, at a constant 37 degrees Celsius, ignoring the patient's cold state. Explanation: alpha-stat management does not correct for temperature, it maintains a stable electrochemical neutrality and preserves cellular enzyme function by keeping the uncorrected sample normal at 37 degrees Celsius. pH stat, by contrast, actively temperature corrects the values and often requires adding CO2 to keep up with the physical changes in gas solubility at colder temperatures. A sudden drop in the venous reservoir level, accompanied by chatter/shaking of the venous lines, is a classic sign of A. A mechanical failure of the oxygenator membrane. B. Air lock or air entrainment in the venous line due to excessive gravitational or vacuum pull. C. An overdosage of protamine sulfate. D. Excessive flow through the arterial filter purge line. Answer: B. Air lock or air entrainment in the venous line due to excessive gravitational or vacuum pull. Explanation: when the kinetic pull, vacuum or gravity, on the venous line exceeds the actual blood volume coming out of the patient, the thin walls of the veins collapse around the cannula tip. This stops flow, causes the lines to violently shake, chatter, and can pull air past the insertion site, leading to an airlock. What does a coaxial or double-lumen cannula typically allow a clinician to do during a peripheral CPB setup, e.g., femoral access? A. Return blood and deliver cardioplegia simultaneously through the leg. B. Provide both arterial return and venous drainage through a single vascular entry site. C. Filter macroemboli using two separate mesh levels. D. Prevent the leg from becoming ischemic during extended bypass runs. Answer: B. Provide both arterial return and venous drainage through a single vascular entry site. Explanation: double-lumen cannulas, like Avalon or bicaval cannulas, feature two concentric channels within a single tube. They are heavily utilized in peripheral setups or ECMO, allowing the team to drain dark venous blood and return red arterialized blood through a single puncture in the internal jugular or femoral vessels. Which monitoring parameter provides the earliest and most direct warning that the gas supply lines have accidentally become disconnected from the oxygenator? A. A sudden drop in the circuit's exhaust/exhausting gas line or inline PA2/SO2 readings. B. A sharp climb in the mean arterial pressure, MAP. C. An immediate drop in the reservoir blood level. D. A visual change in the color of the venous line blood. Answer: A. A sudden drop in the circuit's exhaust/exhausting gas line or inline PA2/SO2 readings. Explanation: if the fresh gas line disconnects, gas exchange instantly stops. Inline blood gas monitors, CDI, or continuous oxygen saturation probes on the arterial line will immediately flag a catastrophic drop in oxygen saturation, SO2, and partial pressure, PA2, long before physical changes become obvious to the naked eye. What is the role of an hemoconcentrator, ultrafiltration device, in a CPB circuit? A. It removes white blood cells to decrease systemic inflammation. B. It passes blood across a semi-permeable membrane to remove excess plasma water and low molecular weight solutes while keeping cellular elements and proteins. C. It actively thickens the cardioplegia solution. D. It works as an active backup pump head. Answer: B. It passes blood across a semi-permeable membrane to remove excess plasma water and low molecular weight solutes while keeping cellular elements and proteins. Explanation: hemoconcentrators use hydrostatic pressure gradients, ultrafiltration, to pull fluid and small waste products out of the bloodstream while preserving red cells, platelets, and clotting proteins. This is crucial for reversing the severe hemodilution caused by the circuit's priming volume. What type of monitoring is used to gauge the adequacy of systemic perfusion when a patient is under deep hypothermic circulatory arrest, DHCA? A. Finger pulse oximetry. B. Radial artery pressure waveforms. C. Near-infrared spectroscopy, NIRS, and electroencephalography, EEG, flatline validation. D. Pulmonary artery diastolic pressure. Answer: C. Near-infrared spectroscopy, NIRS, and electroencephalography, EEG, flatline validation. Explanation: during DHCA, the main CPB pump is turned completely off to allow bloodless repairs of the aortic arch. Because systemic flow is zero, traditional pressure monitors show nothing. Clinicians rely on EEG to ensure metabolic activity has slowed to a halt, burst suppression/isoelectric state, and NIRS to closely monitor the brain's remaining reserve of oxygen. Why must the occlusion of a roller pump head be checked meticulously before every surgical case? A. Over-occlusion causes severe mechanical hemolysis, while under-occlusion allows internal backflow, slippage, reducing true forward output. B. Over-occlusion slows down the electric motor driving the pump. C. Under-occlusion creates a vacuum that pulls massive air from the room. D. It regulates the cooling rate of the heat exchanger. Answer: A. Over-occlusion causes severe mechanical hemolysis, while under-occlusion allows internal backflow, slippage, reducing true forward output. Explanation: if a roller pump is too tight, over-occluded, it crushes red blood cells against the tubing walls, causing massive hemolysis. If it is too loose, under-occluded, blood slips backward across the pump head when pumping against downstream systemic pressures, meaning the flow rate displayed on the machine will significantly overestimate the actual volume of blood reaching the patient.